Okay, uh, good evening, everybody. I'm Dr. Sandeep Singh from Delhi. Today, we'll be talking about basics of arthroscopy. So, I believe everyone is post MBBS here. Can someone can you briefly introduce yourself? I guess, am I audible to everyone?
Hello, yes, sir.
Okay. So, we'll start.
Yeah, please start.
Yeah. So basically, what is arthroscopy? Arthroscopy is a surgical procedure which is done. Just a minute. Yeah, it's a surgical procedure to diagnose and treat your joint structural problems, which often cause pain, instability, or other dysfunction. The surgeon uses an arthroscope, which is basically a long, thin tube with a video camera and a light source at the end, which is the your main instrument while doing the arthroscopy. What is the meaning of arthroscopy? This word arthroscopy has come from basically a Greek word, arthro, which means joint, and scopian, which means to look within the joint. So simply as you see a room through a keyhole instead of opening the doors. So basically, sometimes it is also called a keyhole surgery. So this term is also very commonly used, especially by the layman when the patient comes to you in your clinic. So he asks, "Sir, will it be a open surgery or will it be a keyhole surgery?" So basically, he means will it be arthroscopic surgery or will it be a conventional surgery where a long incision will be given? Going back to the history of arthroscopy, the arthroscope was first, the endoscope basically was the first used in 1910 by a Swedish physician named Hans Christian Jacobius, which he designed an endoscope instrument basically to look inside the abdomen. So endoscope and arthroscope, basically they're laparoscope, basically they're all the same. They use the same technique. They all do a keyhole surgery. It only depends which region of the body you are exploring. So if you're doing an abdominal surgery, it is basically called a laparoscopic. If you're doing a joint surgery, it is called an arthroscopic surgery. Or in spine, we simply call it a spinal endoscopic surgery. The first knee arthroscopy was basically done by Dr. Nortot, a Danish surgeon, and this was done in 1912. And the first shoulder arthroscopy was done by Dr. Berman, who was an American surgeon, and this was done in 1931. And ever since, there has been advances, there have been refinement in the field of arthroscopy, so much so now that it has become the treatment of the surgical procedure of choice. Many patients, they just walk into the clinic and they say, "We don't want an open surgery, we want an arthroscopic surgery." So definitely we'll see why the arthroscopic surgery is so much in demand. What is the advantages of the procedure in the subsequent films? Who performs an arthroscopy? So basically, an orthopedic surgeon who has been trained into this procedure of arthroscopy, they perform the arthroscopic surgery. Arthroscopy, as such, is not a post-graduation branch. It is basically a subspecialty of orthopedics. So orthopedics, if you, I mean, it's a post-graduation degree. You get a MS degree in orthopedics when you do your PG, but it has many subclasses now. You can become a spine surgeon, you can become an arthroscopic surgeon, you can do a arthroplasty, that is joint replacement, or you can be a foot and ankle surgeon, or you can then be a hand surgeon, or you can be doing a pediatric orthopedics. So basically, after doing your general orthopedics, if you want to specialize, as I mean, the case, it is like equivalent to DM in surgical fields. Like you have gastroenterologist, cardiac surgeon. This is basically equivalent to that. So that means that arthroscopy is really needs a lot of training, a lot of hard work goes in after your basic post graduation degree to become an arthroscopic surgeon. So what does an arthroscopic system look like? So here you can see basically an system comprises of an arthroscope, which I told you, which is the main working channel, the main working instrument, which has a light source and a light cable. Here you can see in the shelf, it is all kept, and the camera system. There's a monitor. Monitor usually should be more than 20 inches in size. These are, and today we have got flat screen monitors, which are HD monitors. So all those advances have taken place. So various different kind of arthroscopes are available in the market, and usually in India and abroad. I mean, they are mostly German. German and the American system scope which are used. Medtronic is one company which gives an arthroscope. So and it's a quite expensive setup, and a good arthroscope scopic setup and the instrumentation will be something around 20-25 lakhs in India. So coming on to the parts of the arthroscope, there can be mechanical instruments like probe, punches, grasping forceps, or they can be motorized instruments like shavers. The use of it is basically, I won't go into the basics of, I mean, the more advanced detailed things. For an MBBS level or a basic orthopedic postgraduate level, I mean, you just need to know these instruments. So they can be electrosurgical instruments like electrocautery, radio frequency ablation, the laser, or they can be special instruments. They come in sets like ACL set. The most common for arthroscopic surgery is by far the ACL, that is anterior cruciate ligament reconstruction. That is the knee surgery, or it can be a PCL set, which is posterior lateral ligaments of the knee joint, or it can be a meniscal repair, or it can be a osteochondral autologous transverse surgical procedure. Now, here you can see the basic, the main working instrument. You can see it has an eyepiece. Okay, attachment for the light cable is there. Then there are series of lenses. Okay, and there are optical fibers which transmit the light into the joint. So, coming out to the optical properties, basically the arthroscope comes in various diameters, and the most commonly used diameter is 4 mm cannula. Basically, it is used for the larger joint like the knee joint or the hip joint also. Smaller probes of 1.9, 2.7, they are basically used for the smaller joints like ankle, the wrist joint, or the elbow joint. Then another interesting point here is angle of inclination. Basically, it is related to the field of view. So here you can see it can be a 30-degree scope or a 70-degree scope. So basically, it all depends on the field of vision, your field of vision, where it is focusing and how big is your operating field. Here you can see the angle. The angle in the 70-degree, as visible in the diagram, it looks a little downwards, sideways. Okay, 30 degrees more or less straight, and hence the diameter. The yes. Hello. Yes. Am I visible again? Yeah. So then comes the light source and the fiber optic cable. So light source is typically of 300 to 350 watt. That is the requirement. And the light source can be of tungsten, halogen, xenon source. And all these have different properties. In something, one is better than the other, and sometimes the other part is better than the other. And they all have a lifespan in measuring in hours. So these should only be activated till when the scope is really inside the joint cavity. Okay, so to protect the light source and to maximize the lifespan of a light source. So again, the camera system. Okay, here you can see in the picture. See, it should be comfortably positioned so that the screen, the monitor is right in front of the eyes of the surgeon, and surgeon is on the side of the operating side. Here you can see the surgeon is performing a knee arthroscopy, and the assistant, the sister, is standing next to him, and the monitor is right across the patient. So it should be so placed, the setup in the OT should be like that. It is comfortable position for the surgeon. And obviously one has to maintain all the sterility in the OT. And as such, the whole team should be able to see the monitor and should be able to participate and give their best during the surgical procedure. Again, coming on to the camera system, nowadays a lot of advances have taken place and a lot of models like you use your cell phone. There are so many features there, upgradation every 6 months or a year. Same goes with the arthroscope also. So camera, initially they had one chip. Now most of us are using a 3-chip camera. And then the camera cable has shown to improve in properties and all those things with the recorder and all this you can see downstairs. Now HD is the main thing. HD, we mostly use a HD camera. And then it also has a monitor and a recorder. Monitor, as I told you, it should be at least 20 inches and should be placed at a comfortable level so that the whole team is able to see it. And most of our patients, they always ask for a recording of the procedure. So we do have a video recorder where we put in a CD and the whole procedure is recorded in the CD. And this CD recording the procedure is also good for the surgeon as such, because today the amount of medical legal cases are going on, and so it is always better for the surgeon to record the whole process, at least for his records. You may not be, the patient may not ask for a recording, but you should always keep a surgical recording for your own record, for the follow-up or going back into the surgery if something goes wrong. So in the future, if you want to look back, so recording is a must. And these are the all instruments, the various instruments which are used. So it can be a forceps, and punches. Basically, punches where you bite, uh, take a punch, you take a bite of the tissue. It can be a grasping forceps to hold the menisci or the ligament, or it can be a scissor, again to cut the instruments. There are various kinds of probes and knives and radio frequency ablation, the laser. There's so many instrumentation, and they are all very delicate instruments, and all should be kept very carefully. They come in a beautifully packed, say, boxes. So the basic arthroscopic kit, it contains of a main is the arthroscope, light source and the cable, camera system and the monitor. Then your instruments, which is probe, gasper, punches, okay, and the motorized shaver. This shaver usually used to shave. It is like a motor. It shaves off like you do your shaving, like the guys. So it just shaves off your extra fat, okay, and the menisci. So these are basically used for arthroscopic procedures. And of course, then comes the implants. Implant can be a suture implants, which are sutures of various materials, of various strength, various sizes, which are used to, repair your menisci or repair your ligaments. Okay. And then there are certain devices like clips are there are hooks are there are buttons, there are screws which hold on to your artificial anti-cruciate ligament, which we put and fix. So again, it can be of various materials. It can be of titanium. And nowadays we usually use screws made of a biodegradable material, which is not visible on the X-ray, and it gets incorporated into the bone as with the time passes. Of course, whatever the advances take place, the cost of the surgery increases. So it all the what type of instrument we are using, what type of sutures or the implants we are using, it will all depend on the patient's choice and the surgical package. And these instruments have to be kept and used very carefully. They are very delicate instruments. Okay. And when it comes to the sterilization part, usually I'll show you they are used uh, in a sterile packing. We before starting the surgery, we put these instruments in a, say, plastic sheath, plastic coverings, which are sterile, because all the parts cannot be autoclaved. There can be like the lens and everything, the plastic, they get melt if you put them in autoclave. So basically they are ETO'd. Okay. So major delicate part they are ETO'd, and then the plastic sheath, a sterile plastic sheath is used during the surgery. And the parts which are metallic parts, which are heat stable, they can be safely autoclaved before the surgical procedure. Now, what are the types of arthroscopy? Arthroscopy basically, it is divided in the region where you are using it. As I told you before, the most common surgery, I'll say 90% of the arthroscopic procedures take place in the knee joint. Okay, then the second most common will be shoulder arthroscopy, and third will be hip. And after that, it comes to the small joints like elbow, foot and ankle, hand and the wrist. So why do we? Basically, what are the indications on arthroscopy? As I told you, arthroscopy does all those procedure which can be done by the conventional open surgery. But in the open surgery, as you all know, there are big scars. Okay, so nobody prefers these days. There's a lot of blood loss. So basically, all those indications. So the indication will be, uh, I mean, it arthroscopy can be basically of two types. Here we can say, like, it can be a diagnostic arthroscopy or it can be a therapeutic arthroscopy. Diagnostic, as the name tells, where you are not sure about the diagnosis. Like the X-ray doesn't show anything. On the MRI, the things are not very clear because I mean the joint, it is a 3D image. Okay, but on the MRI you see a 2D image. So sometimes the things are not very clear. You actually can't follow the ACL. You're not sure if it is torn, if it is completely torn, if it is a partial tear. Same goes with the menisci and the other structures in the joints. Okay, so in that case, we call it a diagnostic arthroscopy, where we put in our arthroscope, we inspect each and every structure by our own eyes. Okay, so we are more sure about the diagnosis. Okay, and then we can formulate the treatment plan. The treatment can be done like if there's a torn ACL, it can be repaired in the same sitting. Or sometimes we realize that it's a case of chondromalacia or there's a cartilaginous defect, then we can uh, turn on to the medical treatment, okay, or other cartilage replacing procedures and all at a later date also. So indication will basically fall into knee pain, knee instability, okay, and sometimes infections of the knee also, like in tuberculosis of the knee joint. Sometimes arthroscopy is used to bring about the debridement. So instead of giving a whole lot of scar and doing a lot of bleeding, a small incision, and you can debride the whole joint. You can do a synovectomy. You can I mean excise the whole infected synovium. And again, in the shoulder joint, we do it for rotator cuff tears. We could do it for frozen shoulders, shoulder impingement syndrome. There are a whole lot of indications now which are being tackled by arthroscopic surgery instead of a conventional open surgery. And I'll say rest again. Even the rheumatoid specialists, they are using arthroscopy to inspect the joint, to excise a ganglion cyst, or to release a carpal tunnel. So these procedures also are now being done by arthroscopy. So basically, when do we do an arthroscopy? We do an arthroscopy when all our medical treatment fails, where want to make a diagnosis, or certain procedure like ACL rupture, where there's no medical treatment. I mean, you have to do a surgery, rotator cuff tear, where you have to do a surgery. Okay, so these are the again, but arthroscopy is never done for like for instance the knee joint. If there's a ACL tear, suppose you met him with an accident, the patient comes with an accident and there's a swelling around the knee joint, there's a lot of bruising and ACL is torn, which we find out on the MRI. The arthroscopy is usually not done the same day. It is not an emergency surgery. It is done after 2 to 3 weeks when the inflammation has settled down, the swelling has reduced, when the skin lesions have healed, okay, and when we are sure that no internal infection has taken place. So arthroscopy is basically a planned surgery. It is an elective surgery. It is usually never done as an emergency surgery. Emergency condition where will be like a foreign body into the knee joint. A needle has gone into the knee joint or some other joint. There you can say it is an emergency procedure, but otherwise it is always an elective procedure. So what do you do before arthroscopy? First, of course, we have to make our diagnosis. Okay, we have to do a PAC of the patient. PAC is pre-anesthetic checkup, where anesthetist does all the basic blood work and the urine investigation, ECG, sometimes echocardiography and X-ray chest, and make sure that the patient is fit to undergo the anesthesia and the surgical procedure. Okay, then the patient has to give consent. The surgeon must be very careful to obtain a written consent. Nowadays, we use a written consent. Okay, previously we used to write for each and every patient. We used to mark up and write with our own hand. Now they all come in the printed forms as per NABH guidelines and other regulatory authorities. We have the written consent. We just need to fill up the patient's name, the surgical procedure, and we need to take the sign of the patient along with the witnesses and the doctor itself. Okay, we must make sure this patient is not allergic to any medicine, okay, which are going to be used during or after the surgical procedure. And obviously patient has to be kept NPO, that is nil per only. He is supposed to be empty stomach for at least 6 hours. So usually the procedure is performed in the early morning. So post midnight, we ask patient not to eat or drink anything by mouth except maybe some essential medicine which he might be taking for like BP or sugar, which he can take with a sip of water, like any other surgery. So basically, all the preparations are like any other surgery, major surgery, which is going to be performed under GA. So what happens during arthroscopy? As I told you, we have discussed all the procedure. So arthroscopy basically nowadays it is performed an outpatient procedure. I mean, you can admit the patient in the morning, do your pre-surgical preparation in an hour or so, do the surgical procedure, usually which again takes around 1 hour or maybe 2 hours, be it knee or shoulder joint. Usually, I mean, all arthroscopic surgery, a good surgeon can finish in 2 hours. And then patient is kept under observation for say up to 4 hours, and probably by the evening you can discharge the patient. So that is the beauty of this procedure. Had you been performing an open surgery, the patient would have been admitted and kept in hospital at least for 2 to 3 days. But for with arthroscopy, the hospital burden also, I mean, decreases that way. So in countries like US and UK, where I mean, part of the bills are taken care of by the government, so they are very happy to perform arthroscopic surgery. So that's why it has been promoted. One of the reasons is this. Okay. So I'll like to show you a small video just to see what is done in an arthroscopic procedure. This is basically arthroscopy of the knee joint.
This procedure repairs your knee after a tear of the anterior cruciate ligament, commonly called the ACL. This ligament is in the center of the knee. It helps anchor the femur to the tibia. This surgery can allow you to regain normal knee function. In preparation for the procedure, you are anesthetized. The surgeon creates a small incision in the front of your knee. This exposes the patellar tendon, a thick band of tissue attached to your kneecap. The surgeon removes a portion of this tendon and some bone where it is attached. This tissue is called a graft. It will be used to replace your damaged ACL. Next, the surgeon creates a series of small openings in your skin. An arthroscope is placed through one of the openings. This is a viewing device that allows the surgeon to see inside your knee. More surgical instruments are placed through the other openings. The damaged ACL is removed. Using a guide pin, the surgeon carefully drills a tunnel through the tibia and the femur. The graft is pulled through this tunnel and into the position your ACL once occupied. The ends of the graft are anchored. Over time, new tissue will grow along the graft, strengthening the joint.
So that was just to show you briefly, how is the ACL repaired. So there are a number of techniques, there are a number of grafts being taken. I won't go into details, probably that is not required at your level. Okay, so I mean, this was just a basics, what procedure we can do, and that was the most common procedure, the ACL reconstruction. Okay, again, now here you can see the typical OT setup. You can see the knee has been draped, okay, it is exposed. So you can see the monitor right there, the whole system being there, the sterile table with all the draping sheets and your instruments there. Okay, the surgeon will be standing on this side. The anesthetic curtain is put, so the anesthetic is on the other side. Usually should not be interfering or to maintain the sterility of the environment. Okay, so this is how a typical OT looks like when you're starting an arthroscopic procedure. So the standard portals, okay, I'll just enumerate. So these are basically the portals. There can be a number of portals, is basically the openings from where you put in your, you need one portal to put in your arthroscope. You need one opening to put up your irrigation solution, the saline. We use saline. The joint, I mean, they don't look that much open, okay, during a surgery. How do you inflate them? Like a balloon, you inflate them with saline, which runs like a continuous source. Sometimes we use even up to 100 liters of saline. So it's a continuous irrigation system. From one port it goes in, and the same port the suction oil comes out. Okay, and usually 3 ports are required, and the third port will be for your instruments, the basic instruments you need to put in and perform the procedure. So these are usually the 3 most common ports which are used. You can see it is marked on the knee. So we use the infralateral port, inframedial port, okay, and supramedial port. These are the most common port. Otherwise, it depends on the surgeon from where he's comfortable putting. These are not standard. You can put the incision anywhere, and like a cricket field, there are certain well-known points where you place your fielders. But I mean, the fielder can be anywhere on the field. Same, the incision can be anywhere in the knee. So whatever the surgeon feels, you can and see the size of the incision. The incisions are just 0.5 to 1 centimeter, one incision. So there's practically no bleeding. There's no scarring. And what do? You performed a good arthroscopic procedure. What do you do next? So we do give a well-padded bandage in the OT. We put in like for knee, we usually put in a brace. Okay, it's called a long knee brace without any hinges. Okay, so that's to immobilize the knee joint. And you can give ice packs in the ward, the proper analgesics are given. I mean, all the medicine, antibiotics, everything is given. Then patient is usually shifted to the room, and he is kept in the room to observe the patient for hemodynamic stability. We monitor his blood pressure, his pulse rate, and we look for any bleeding, and we make sure his respiration is good. There's no other complication. Okay, once we are sure, this usually takes around 3 to 4 hours. Once we are sure the patient is doing well, he's stable, we can discharge the patient. So why do we do arthroscopy? Why it is so in vogue these days? So basically, as you have seen, it reduces the post-op morbidity. Why? Because the scars, the incisions are very small. There's no bleeding. There's no scarring. There's hemodynamically the patient remains very stable. There's no inflammatory response. Okay, and for the surgeon as such, I mean, it is a very good visualization. It is a very good visualization into the field where we can see all the structures. There's no blood in the field because of the continuous irrigation. Here you can see the irrigation. This is how you do the irrigation. There's the cannula, and with the, like, you give IV fluid, you give irrigation. Okay, it reduces the hospital stay. It reduces the complication rates. And the patient is happy. The follow-up evaluation is much better. And all the other complications of general, I mean, when you give a bigger scar, the scarring is more, the post-operative range of motion, sometimes it is because of the big scars, it can be less. So all those advantages of the procedure itself and the disadvantage of the conventional open surgery can be negated. But although it has advantage, but it does have some disadvantages also. So what are the disadvantages? Well, you are working through small portals with delicate and fragile instruments. As I told you, I mean, the instruments are very fragile and plus they're expensive, okay? And they are small portals. Sometimes it is not very easy. You need to be trained well enough. And a general orthopedic surgery just cannot do de novo arthroscopic surgery. I mean, he might be able to fix bones, do plating, nailing, all those, but arthroscopy, as I told you, it is equivalent to DM. So you need specialized training for this. So it has a basically a long learning curve. So a lot of hard work goes in, a lot of resources go in. You cannot sometimes, I mean, some doctors who are doing arthroscopy, I mean, still they don't have their own arthroscope. Even, I mean, after so many years of practice, because it is an expensive thing and it's difficult to maintain. So practically, I mean, we get it on rent. At least in India, in Delhi, we get it on rent. Per case, we pay a certain amount to the supplier. So maneuvering the instrumentation can be difficult, can be very difficult at times. Sometimes it does happen, and one should not be afraid to convert into an open surgery. Sometimes you struggle with your report, the camera system is not working properly, the right source is not working, or whatever. The bony structure is so that you are not able to negotiate inside the joint, you're not able to visualize the. So the surgeon should never be hesitant to abandon the procedure and do a conventional open surgery. So in your consent also, you must make a line saying that if during the procedure the surgeon finds there's a need to convert it to an open surgery, you give consent to do that also. Okay, so you must take the consent beforehand. As I told you, it requires experienced surgeon. Every orthopedic surgeon just can't perform. Time consuming, it is not exactly. Initially, yes, if you are doing your first 5 or 10 arthroscopy, yes, it is time consuming. It takes a lot of, I mean, you need a planning in your mind, a three-dimensional lookout. Okay, because as I told you, it's a keyhole surgery, so your vision is very limited. So you should exactly know what you are looking at. In the open surgery, everything is open. You can see the big femur, the big tibia, the fibula, all the ligaments. When through an arthroscope, the field is really, really magnified. It is like working under the microscope. It is like working under a microscope. Okay. So it is time going, but initially, once, as I told you, I mean, good surgeons, the experienced surgeon, they can do an ACL within 30 minutes, 30 to 45 minutes. Shoulder surgery, maybe 1 hour, 1.5 hours, depending on the type of procedure you are doing. It requires special instrument. That is true. That requires a special instrument. Okay. So all those instrumentation, they're expensive, they're not easy to procure and keep, as I told you before. I told you this before. So what are the potential risks or complications of the procedure? As with any other major surgical procedure, there can be reaction to the anesthesia, the various drugs used during the procedure. There can be blood clots, which can lead to deep vein thrombosis. So that's a major complication. It can lead to thromboembolism or all those cardiac and respiratory other complications. There can be damage to the surrounding tissue and the nerves. But again, as I told you, since it is the chances of all this is very less as compared to a conventional surgery because you are working in a magnified environment and your instruments are very delicate. So, I mean, a lot of force is required, a lot of error is required to cut a nerve because you can touch a nerve, but to cut that nerve, I mean, you need a lot of force when you're doing arthroscopically. Okay. Post surgery, there can be excessive bleeding or there can be swelling into the joint. Later on, I mean, there can be infection, as like with any other surgery. But all these complications are very, very less as compared to a conventional procedure. There are certain contraindications also. So, what are these contraindications? Well, I believe only absolute contraindication is one. There's infection at the skin of the skin at the site of your surgery. Okay, where you intend to give an incision, and suppose there's a local infection there, then obviously you'll have to abandon the procedure. You have to control the infection first, and then go for the surgery. Then there can be relative contraindications. I mean, like complete or partial ankylosis. This again, when there's ankylosis or limitation of movement of the joint, then your vision becomes really, really restricted because you're not able to bend the knee or turn the hip, even the not the knee itself. When you're doing a knee surgery, the hip movements are very, very important also because the leg as such, the lower limb as such have to be sometimes turns on the other side. You have to flex it, you have to extend it, okay, abduct the hip, adduct the hip. So if there's a fusion of the joints, the mobility can be compromised, the vision can be compromised. Probably in those cases, you will refrain from doing an arthroscopic procedure. And suppose the knee joint is very, very flail, you just don't have any control. So then it really becomes difficult to put an arthroscope and hold the limb from the other side. And then the chances of error becomes really high. Can just go anywhere and it can be a dangerous procedure. So what is the recovery after doing the arthroscopic procedure? What do you expect? See, as I told you, the patient can be discharged the same day, and like we'll talk about ACL, like the most common procedures. The splint is worn for a few days, 3 to 4 weeks. The first dressing change usually takes place after 3 days. Patient is most of the cases, patient is about allowed to bear weight with the splint on. Partial weight bearing is allowed from day one. So right from day one, he can go to the washroom by himself. Okay, that's the beauty of the procedure. With open surgery, you cannot probably do all this. And then some people, if they have a sitting job, you can allow them to go to work in 3 to 4 days. So that really cut down on your immobility. The recovery is very fast. But as such, the rehabilitation, again, which is a very important part, the physiotherapy or the occupational therapy after the procedure, that's again a very major, major part to get back the functional outcome which we intend to get. Okay, so the physiotherapy usually takes around 3 to 4 months post the procedure. So running, I mean, playing sports like cricket and football again, this is usually, I mean, it can take anything between 3 to 6 months post procedure, depending on the progress of the patient. Thank you very much. So that was in brief. If you guys have any question, you can ask me.
Please ask any question. I think no question, sir.
Okay,
Thank
fine.
you.
That's. I hope everything was very clear, or it was very unclear. So these are the two conditions when people don't ask questions. So I believe it was the first one.
Yeah, one question maybe.
Okay, sure. So shall we?
May I ask one question?
Yeah, please go ahead.
Well, I want to know about the costing of how much maybe suppose knee joint
How much?
ACL repair. How much it
Yes.
cost? How much?
Sorry, can you
ACL
repeat your question?
ACL repair. If it is
ACL repairs.
AC
Yes. What do you want to know about it?
anterior cruciate ligament repair
Yes.
in cost, how much it may cost?
Cost. Well,
Idea. We want an
again,
idea
it
about
depends from
cost.
patient,
Okay.
the setup also, and again the type of implant. As I
Yes.
told you, the bioabsorbable or roughly, if we talk about the ACL repair in India in a smaller hospital, say a 50-bedded hospital, will be something around 1 to 1.5 lakhs. But in a bigger hospital like Max and Fortis, it will be something around 2 to 2.5 lakhs. Okay. Did you get the answer?
Let's. Yeah, I got this.
Okay.
Thank you. But,
Any other question?
I have wondered, most of the patients are athletes or any giant
Yes. So
people
yes,
also
good question.
may
So
be
arthroscopic surgery,
need
another way
this.
to call it, another name is the sports injury. Okay, so it's the sports, because all these ACL tear, rotator cuff tear, that usually takes place in sports persons, athletes. So arthroscopic is usually done by the, I mean, it's again, if you want to say, it's a sports injury department. So that is the main work of these doctors in the sports injury department, is to do an arthroscopy. Okay. Any other question or doubt on, or shall we end this meeting?
Yes, sir.
Okay, so it was nice giving this presentation to you guys. In future also, I mean, if you have any queries, you can simply tell DMHCA, and I'll be happy to answer them. Thank you. Good evening.
Thank you so much. Good
Bye.
evening.